Hello, everyone. Good morning, good afternoon, good evening, whatever is relevant to you. And welcome to the Global Health Policy and Research Forum 2020 Symposium. My name is Karen Greppen, and I'm joined here with the panelists tonight and Kathy Reyes, wherever she might be on your screen. We are the host and co-hosts for the session tonight. Without further ado, I think we'll get started. Fong, if you could share with you our slides. So as I mentioned, this is the 2020 Global Health Policy Research Forum Symposium. Next slide. We are a new organization that is getting underway. This event tonight is a series of events that will take place over a couple of weeks, and it builds upon a number of symposia that were previously organized, starting back in 2016 at American University. And then 2 years ago, we held one in advance of the Health Systems Global Conference in Liverpool. And this year, of course, we are online. Next slide, please. Just to give you a little background, this is the organizing committee. I won't spend too much time on it because I know you've met some of us, and we will be hosting these sessions over the coming weeks. Next slide, please. If you are interested in finding out more about the organization, we have a website, and we would encourage you go there to visit it. There's also information on the website about the upcoming sessions that are still part of this symposium, as well as the recorded presentations that were from the previous sessions during the symposium. Next slide, please. I want to just take a few minutes to thank our sponsors who have provided financial support in order for this event to take place. So the Johns Hopkins Alliance for a Healthier World, as well as the thematic group SHAPES, which is part of Health Systems Global. Next slide. Tonight we are on panel 2, and we're going to be talking about government tensions in health policy. You'll see that there are 3 more sessions that will be held as part of the symposium, all of them on a Tuesday night. Because of the complexity of trying to organize a symposium across every time zone in the world, you'll see that some of them are all over the place. We were trying to accommodate some people who are more in the Asian time zones with some of them, and some more in the European, North American time zones. So do keep an eye on which time zone each session will be held. Those are in GMT time, so please adjust your clocks accordingly to that. We will be taking a couple-week break now between now and the next one because of Health Systems Global Conference, which will be taking place mostly next week. And then the rest of the sessions are through the end of November and into December. Next slide. So tonight we have a wonderful lineup of speakers. I just want to introduce them to you briefly. After we get started, I won't interrupt again to introduce each of them, so they will kind of lead into each other's slides. So we have 6 panelists tonight. We have Sara Fischer, who is a PhD candidate at Georgetown University. We have Ligia Paina, I probably said it wrong already, who is an assistant professor at Johns Hopkins School of Public Health, and from what I understand, just came back from maternity leave. So wonderful to have this as one of your first things back. Sumegha Asthana, who is a doctoral student at Jawaharlal Nehru University. Again, I'm not doing great on pronunciation. And then we have Abigail Neel, who is a research associate at Johns Hopkins Bloomberg School of Public Health as well. Dodoo, who is at the Ministry of Health in the University of Ghana and is also associated with the University of Cape Town. And then finally, last but not least, we have Judy Dare, who is winning the prize for latest time zone. She is a lecturer at Curtin University in Australia. So that is our group. Just in terms of some logistics, next slide, please. We will let each presenter go. They will have approximately 5 to 7 minutes to speak, and then they will be asked to move on to the next presenter. If you have questions at any time, please put them in the Q&A box at the top of the screen. Kathy will be monitoring them and she will be reporting back. We will save all the questions until after all the speakers have had a chance to talk. If you have any more logistical kinds of questions, please put those in the chat box. We have somebody monitoring that one as well in order to see if there's something that they can help you out with. Finally, in the next couple of days, you will likely receive a short survey via email from us. Please take a few minutes to fill it in. We're trying to get your feedback in terms of how we may want to organize future events of this nature. So your feedback is super important to us. Please take 2 minutes to fill that in. And without further ado, we will move on to our first speaker. And so we'll load those slides as well.
Hi, can everyone hear me? Cool, perfect. Okay, great. So good morning for me, good afternoon, good evening for the rest of you, wherever you are. And happy election day to anyone who might be tuning in from the US. We'll see how that goes today. My name is Sara Fischer, and I will be presenting a piece of my dissertation, which is entitled Who Owns Development Projects? Theory versus Practice in Malawi's Health Sector. So ownership, of course, is a buzzword, but as you look around at facilities and communities in many low-income settings, you begin to notice donor or project branding, as you can see from this sign at Malombe Health Center in Malawi. So I began to ask myself, what is meant by ownership and who exactly is or should be doing that owning? Next slide. So I want to suggest that the way that we think about ownership is wrong. Basic principal agent theory would suggest that there's a principal, the donor, that contracts an agent, the recipient, to undertake certain actions on their behalf, development projects. However, in development, there are two major problems with that assumption. First, given the pillar of ownership in aid effectiveness, the principal really should be the recipient, with the donor as the agent. And this would flip the conventional principal-agent relationship on its head. Next slide. But there's a second issue that emerges, and this is that development does not simply consist of a bilateral and donor and recipient. There are multiple cascading principal-agent relationships that occur. Next slide. And I will argue that these other actors should all be acting as principals to the external actor agents. So to demonstrate, I have examples from various levels across the Malawian health sector from interviews and field notes during my year there. Next slide. So first here you'll see often national government stakeholders say that their projects being brought to Malawi are government of Malawi projects, and the partners are really just supporting, as in this quote from a ministry official who says, we're using the government to implement the project with the understanding that this is a government project. These other international NGOs, they're simply supporting us to reduce the malaria burden, but the malaria burden is our issue, it's our problem. So of course, this is the way it should be, but of course, there's also more to it than that. Next slide. So at the next level, you have districts. With an increasing focus on decentralization, districts should be taking as much, if not more, ownership of development projects than even the national government, as you see in the first quote here, where a district official says, in terms of implementation, it's the government who's implementing, so it becomes, in quotes, our project and not their project. However, there's sometimes a lack of translation from national to district level, whereby projects are planned at headquarters and districts need encouragement to quote unquote, take ownership. You see this in the second quote, where a supporting partner is pleading with the government officers, don't look at this as a partner-driven activity. It's wrong, it's your own DHO activity. But of course, districts are where projects are actually run. So district employed health workers are also a necessary cog in that system. Next. So here, for example, are two quotes from Government of Malawi Community Health Workers, HSAs. The first one shows the frustration that HSAs often feel with projects bypassing them to implement directly in communities, whereas they consider themselves to be the owners of their particular catchment areas. So one HSA says, others go into our catchment areas without our knowledge. So that disappoints us because when there are activities, as I am the owner, I am supposed to be aware of what's happening, but they just go without our knowledge. Then you also see, even when an HSA does try to take ownership of the project, there's difficulty translating that down to communities, as you see in the second quote, where an HSA says, if we go there and try to remind them about what they're supposed to do, they don't understand. They think the program is for the NGO. So this brings us to the final step of the ownership chain, the intended beneficiaries of all these projects, the communities. Now, all of the frontline workers, NGOs, government officers, they all acknowledge that communities must feel a sense of ownership over projects in order for them to be successful. As you see in this first quote, where one NGO representative says, "We want interventions to be fully owned by the community so that by the time we leave, they are empowered to continue what they are supposed to be doing." However, this is often not the case. And as I showed in the district quote above, I have observed a lot of pleading with communities to try to get them to feel that sense of ownership, but often to no avail. So here, one HSA describes that the community should feel a sense of ownership, that it's their own thing. We had a challenge where we were supposed to receive boreholes. I discussed with them, no, this is important, but I don't know whether it was important to them. So this demonstrates the importance of ensuring ownership, not only at the country level, but also all the way down to communities themselves. Next slide. To conclude, we have seen that there is, of course, an aspect of bilateral country ownership that plays a role in development, but most global health projects are not implemented at the national level, so ensuring country ownership alone is insufficient. We must reconceptualize communities, frontline workers, districts, and countries as principals in the development chain, while seeing donors and implementing partners as the agents. So imagine a world in which the Malombe Health Center sign that I showed at the beginning looked more like this, next, with only the government insignia displayed, and perhaps Mangochi District Council, or even the names of surrounding communities. And that is what I argue that ownership should look like. Next slide. Thank you for your time. I'll stop there, and I look forward to the other panels and the discussion. Thanks so much.
So up next we have Ligia. If you want to just unmute yourself and take over, thanks.
Great, thank you so much, Karen, and good morning, good evening, everybody. It's a pleasure to be a part of this panel. So thank you so much for having me here. Today I'm going to be presenting on the geographic prioritization in Kenya and Uganda using a power analysis lens. And before I get started, I guess I wanted to acknowledge that this is actually an analysis I'm presenting on behalf of a larger team that was part of a larger study, a USAID-funded evaluation through Project SOAR, which Dr. Sarah Bennett led. And next, please. So a bit of a background before getting into the analysis. First of all, just to make sure we're all aware of what the geographic prioritization was. It's a policy that PEPFAR 3 implemented or introduced in 2015. And it was all part of an effort to more effectively spend the resources and target the resources, in this case, to focusing on high burden geographic areas. And the implication was, next, please, Paul. The implication was that in the countries in which this policy was implemented, the resources would be focused in some areas. In other areas where there is low burden of HIV, the resources would actually be taken away and the areas transferred to government support, hence the central support. And this was in an effort to more rapidly meet the 90-90-90 targets set by UNAIDS. And to also in an effort, I guess, as PEPFAR was transitioning to the government to enhance country ownership. So real briefly, the parent study, the broader evaluation, its goal was to provide timely guidance to USAID and USG partners on implementing the geographic pivot. I'll just refer to it as GP because it's a mouthful. And to also look at associations with effects on service delivery and the balance between HIV and non-HIV outcomes. I won't go into those now, but just to say that our focus was on centrally supported districts, and those are highlighted in red for Uganda and the counties in red for Kenya. So next, please. So then the objective of this paper that I'm presenting, next please, was to compare how power is distributed and manifested in the context of the GP in Kenya and Uganda. And we thought that the power analysis was helpful in doing that because it was not a part of our initial objectives, but we felt like it tied together some of the themes that were emerging as part of our analysis. So what we did was we reanalyzed the qualitative data that was collected in 2 rounds. Next, please. And this included interviews at the national level as well as a document review. And it also included longitudinal case studies at facilities which underwent the transition to central support. Next, please, and next. And we use a framework approach with a focus on understanding the GP implementation, the design and implementation actually through Gaventa's Power Cube framework. And I'll go through each of these dimensions in greater detail. Next, please. So I guess as a caveat, Gaventa makes it very clear, and as I think we can all intuitively imagine, that these dimensions are not independent of one another. In fact, they're interrelated and often are used to describe messy issues that come up when power dynamics arise. But for the purposes of trying to simplify what was going on, I will just go ahead and explain each of these in sort of sequence, with highlighting where there are cross-cutting issues. So the first dimension of the Power Cube is the places and levels. And these levels are the arenas where social, economic, or political power exists. And they often form in response to bureaucratic arrangements. And as you can imagine, these are interrelated and messy. Sarah's presentation actually alluded to some of the dynamics between the different levels as well. Next, please. So to be able to tease out or to at least orient ourselves in the level space, we undertook a broad stakeholder analysis just to highlight that actually the actors that are occurring at these levels are in 2 separate sets, and the power dynamics actually occur in different areas. So what the Power Cube analysis allowed us to do is to identify disconnects in this among these relationships. So for example, in both Kenya and Uganda, the stimulus for the geographic prioritization came from PEPFAR headquarters. So in neither of those settings was there a question of whether or not this policy would be implemented, because it came sort of from top down, and there was no connect between the global level and sort of the country level at the national side. At the country side, I mean, it was all filtered through the PEPFAR country team and the PEPFAR hierarchy. Now there was also some negotiations around the how the GP might be implemented, and those are more evident in Kenya than in Uganda, and that highlights perhaps a weaker connection, let's say, between the PEPFAR country team and the national government. Because, for example, in Uganda, there were actually very little awareness of what the policy was among many actors. We thought that highlights a bit of a disconnect between the implementing partners who actually took control of the implementation and the national government who actually has the mandate to implement this, and who, especially in these settings, is supposed to filter through subnational levels and hasn't. Even within the existing fora, both countries were informed rather than involved in the decision making. And at the subnational and local levels, actually, there was very little awareness. And that, again, the IPs were the main drivers of it. So it was top down, and there were a lot of disconnects. Next slide, please. The next dimension is the spaces. And the decision-making spaces reflect on who participates, recognizing the influence of both history and context. And I guess a few things to highlight here is that, next please. In both of these settings, there were some invited spaces, for example, through COP reviews. However, these were not a place where there was more an information sharing again. And in Kenya, I guess I wanted to highlight that perhaps a claim space was that the countries actually started negotiations to modify how this policy would be implemented. And this was not something that we saw in Uganda. Next, please. The third and final dimension are the forms. And this is actually one that is interesting because I think every point has both a visible and an invisible aspect to it. So I'll give you an example. For example, there was a lot of invisibility in how the decision to actually undertake the GP was taken, especially from the global level. However, what was visible were the criteria that were used for district selection in Uganda or county selection in Kenya. So this shows that actually this is perhaps one of the most complicated because it has a flip side to each. Finally, can you next please? I guess I wanted to highlight that there are some cross-cutting areas that also stood out. And some of these involve the tension between local planning processes, which happens sort of in that national country hierarchy that I mentioned, and the transition policy implementation with even the timelines didn't match, let's say, in terms of fiscal years. And that potentially an arrangement like this could potentially exacerbate power imbalances that occur within, let's say, between donors and country governments, and also within governments from the national and subnational levels. And potentially it could exacerbate this historic imbalance of power in areas that are decentralizing or devolving. So next, please, and I'll very quickly share some conclusions and implications because I think I'm a bit over time. Yeah, thanks, Karen. So I guess I wanted to highlight that, although this analysis was done with data that was not purposely collected for this power analysis approach, it highlighted some of the imbalances and missed opportunities across the different dimensions. And these can perhaps undermine efforts to enhance country ownership. Next, please. But I guess what was interesting, and again, this analysis is still in progress, but we thought that it enriches our understanding of the context in which the policies are implemented and to better understand the implementation of policies. And finally, we thought that perhaps this type of analysis could be applied in a more embedded and rapid fashion to inform policies, processes in real time, especially in implementation. I know that in the initial panel of the session, that was one of the areas that was perhaps warranting more discussion. So this could be one example of how to understand power dynamics. And I guess in the context of donor transitions in particular, it's important because, or anywhere systems are in flux, because that's when power dimensions and power dynamics actually become more apparent, let's say. So thank you so much. I'll stop there, and thank you for the extra minute, Karen.
Yeah, great. Well, thank you. And we'll now move on to our next speaker. Sumegha, are you with us? Just make sure you're not on mute anymore.
Thanks, Karen. Good evening, everyone, and thank you for this opportunity. The title of my today's presentation is Why India Demands Development Aid in Health, Perspectives of Government Representatives and Officials Working with International Aid Organizations. Next slide, please. So the influence of international aid, including the financial flows, technical assistance, and commodities in domestic policy making in low and middle income countries is not unknown. Few of these influences include prioritization of diseases on health agendas, changing strategies for national disease control programs, and introduction of alternate governance and financing mechanisms. However, in India's case, international aid's total contribution has never reached above 3% of India's own health expenditure. In a response to a parliament question in 2017, our Minister of State for External Affairs stated that in the last 3 years, India has actually provided more aid to foreign countries than it has received. Though India revised its development cooperation strategy in 2003 and decided to refuse aid to many bilateral agencies, multilateral agencies, and global public-private partnerships, continue to extend their support to the health sector in India. This low quantum and high level of influence of aid makes it important to understand the reasons that India still continues to demand international aid in health. Next slide, please. This study is a part of my doctoral work, which is focusing on understanding the role of global actors in health system strengthening in India, with an embedded case study on World Bank. The data presented here today is a section which is focusing on understanding the motivations of demanding international aid in health in India, and it includes views on all actors, including the bank. through the perspectives of government representatives working at the national and subnational level, and also the professionals working with quasi-government organizations like the technical support units for the ministries and the semi-autonomous agencies which have been created under the projects. The bilateral and multilateral aid agencies which are involved in granting and demanding external aid projects. Data was largely collected through face-to-face and telephonic elite interviews using a semi-structured interview schedule over a period of 8 months. And the respondents were purposely selected based on their involvement in externally aided health projects. Officials working with the aid agencies were searched through the project reports. And the government officials were searched through the ministry website. And again, few of the project reports had their mention. Next slide, please. And the 5 major themes that emerged from the perspectives grouped in the order of their relevance include the overall economic crisis and the scarcity of funds in the health sector in India. India spends close to 1% of its GDP on health, and most of these funds are spent on recurring expenditures like salaries. We see the quotes from both actors from the government side as well as from the actors from the International Health Organization saying that any kind of financial aid coming to India is seen as extra money because the overall scarcity is too low. The next important point is that the perceived lack of technical knowledge in public health officials, which results in a dependence on foreign expertise for finding innovative solutions to healthcare needs. Respondents from both sides felt that the donors bring advanced knowledge and skills than those existing at the national or subnational level. Senior bureaucrats have been quoted saying that we didn't know program management before these donors came and taught us how to do line management, how to record expenditures line by line. While the aid giving agencies, especially the bank, saying that it's the rigor of our design, our systematic monitoring and evidence-based approaches, our accessibility to the global knowledge. These are the reasons because of which the states ask us for aid and for loans. Another important theme which emerged was the rigid administrative structures existing in the public health systems in India. And these procedures limit the effective utilization of funds. The external aid or the money coming through loans is seen as flexible money, which is over and above the money from the central government and the state budgets. And there's a sentiment of ownership which is attached to this money by the state. It's always seen as flexible money, which the states can spend in the areas where they wish to spend. Simple things like hiring consultants for a long time in the health departments in India was not possible under the government procedures, and this money was used for such purposes. Another important thing which emerged was the personal and the professional interest of the policy stakeholders which were involved in receiving aid, like those of bureaucrats which were aiming to achieve results, quick results, or effective projects and programs with the donor support, or those of the policy entrepreneurs based at the international aid organizations, which were aiming to experiment with different policy ideas. Respondents have been quoted saying from the government as well as from the donor side that who do you think sponsor the foreign conferences and trainings of the people sitting in the government offices? The least quoted and the least stated reasons for demanding for aid emerged under the foreign policy and diplomatic relations. Very few respondents perceive that the decisions about receiving aid are high-level decisions which are taken under the compulsions of maintaining international relations. For example, a respondent said that we seek funds because we're obliged under the international trade agreements and the international health goals. Next slide, please. Now, the motivations and objectives for providing aid have been well theorized, and we've heard our previous speakers talking about it. But the reasons for asking aid, especially for non-aid dependent countries like India, remain understudied. The study highlights that the reason for asking aid in India are not limited to the purpose of receiving additional financial support. These reasons vary according to the international aid actors. For example, the reasons for bilateral agencies are very different than those for the bank or the multilateral agencies or the global health partnerships. These reasons have changed significantly over the last 30 years, starting with the financial motives to now moving towards receiving methodological inspirations and receiving support in decision making or enhancing the knowledge and skills of the Indian nationals. More research is needed to understand actor-specific reasons for demanding and accepting aid. If India is striving to the ownership of health systems development agenda and aiming for self-sufficiency in achieving UHC goals, an increase in overall allocation to the health sector, along with simplifying administrative procedures and building technical capacities of the public sector officials is urgently needed. Thank you.
Excellent. Thank you very much. We'll now move on to our next speaker. Abigail.
Great. Thank you. Hello. Thanks for having me today. My name is Abby Neel, presenting on using the Develop-Distort dilemma as a programmatic analysis framework, the impact of the Global Polio Eradication Initiative on health systems. And I'm also presenting today on behalf of my colleagues, Daniela Rodriguez and Kunle Alange. Next slide. So the Develop-Distort dilemma model was first developed by colleagues at the Springfield Center, and they asserted that many well-intentioned public interventions wound up actually causing harmful effects and suggested that intervention approaches within development assistance ought to stand up to a simple but very important test: does the intervention develop or distort the system? The DDD has been utilized in health systems research a few times since then, including most recently by our colleagues at Johns Hopkins, including Dr. Paina. But our goal here was to test the DDD's utility as an analytical tool for studying the impact of health programs or policies on health systems. So we've made some adaptations to the tool here. Primarily at the center, we have these organizational layers, thinking from the polio program out to the immunization health system, and then also the broader implementing context. Next slide. So to do this, we did an analysis of polio eradication activities in 7 country settings: Afghanistan, Bangladesh, the Democratic Republic of Congo, Ethiopia, India, Indonesia, Nigeria, and also speaking with global actors. And we drew primarily on 2 data sources: key informant interviews, as well as sort of a documentary review to describe the polio program and health system in each setting. Next slide. So unfortunately, I really don't have time to go into each cell on this slide, but I'm happy to discuss these findings further where there's interest. But as you can see, we were able to use the Develop-Distort dilemma domains, which are on the left here: actors, functions, expectations, etc., to summarize the developments and distortions that occurred across these 7 country settings. And we found that there really were, in fact, a mixed or simultaneous effects across each of the DDD domains, which often reflected the tension between the polio program and the broader health system's goals. So for inclusion, for example, the polio program had great success in identifying and reaching hard to reach populations as they sort of needed to get to that last 1% for eradication. But these inclusion strategies often did not translate to routine services. So we saw some distortive effects on that side. Next slide. So I think the meat of what I want to talk about is some of the system dynamics that the DDD helped to illustrate for us when we did this analysis of polio eradication. And we found that the development and distortion that occurred depended a lot on the strength of the health system, both sort of the initial conditions when the GPI was started in country, as well as sort of the adaptations and reactions that occurred over time. These figures on your screen are very simplified, and I'm sorry everything appears to be in yellow, but sort of on the one side, we saw some stronger health systems where external investment actually caused an amplifying effect. And in these cases, the influx of resources sort of increased the rate of health system development. Good examples of this from our study are Bangladesh or Indonesia. And in these settings, the phenomenon sort of occurred, I think, in part because the polio activities were substantially integrated into routine immunization and into the public health system from the outset. And so as investment came in, it was sort of able to done in tandem with local governance structures and actually help to sort of expand the functions and the skill sets within the health system. On the other side, in some places where we saw weaker health systems and where environmental and contextual implementation barriers were quite high, a good example of this might be Nigeria. The GPI often looked for ways around these obstacles and kind of dealt with this tension of, do we work through the system or do we work around it? And this led in some settings to sort of an over-reliance on vaccination campaigns and a separation of polio campaign work from routine immunization, and led to the development of what we call parallel systems. So perhaps a separate human resources cadre with different set of incentives, their own M&E or accountability mechanisms. And this was done without a lot of attention to transition or sustainability. I think there was sort of this culture of optimism that we were going to eradicate polio, and so we could set up temporary systems. But as the initiative has gone on over the years, in weaker health settings, some of these functions and structures that were built for polio, while perhaps quite successful and performing well to achieve those programmatic goals, other things sort of began to piggyback on them, and they became sort of a sub-plan for what the health system should be doing itself. And so while there's some sort of efficiency gains of co-delivery through these kinds of polio campaigns, oftentimes then you have a human resource cadre, for instance, that's not integrated into that system. And there's a lot of challenges around institutionalizing those public goods and just sort of an increasing reliance on external actors and financing. And so that's that piece on the other side of a little bit more of a vicious cycle. Next slide. Next, thanks. So a lot of what I've talked about from our country data, but it's also helpful to look at some of the perspectives from our global actors and some of the sort of challenges that they were having at that level about trying to think through what they were doing. So one actor notes that there was sort of a real challenge to get beyond the zero-sum game mentality and trying to convince polio eradication implementers and global actors in particular, spending time on routine immunization is not a day lost and would be beneficial to the program. And just again, some of these tensions at the global level of wanting to think through, can we just substitute for this rather than actually working through the system in order to deliver on program goals. Next slide. So to conclude, I want to just spend some time about how we found the DDD and its utility. We found it was really helpful for evaluating unintended consequences, and it helped us to sort of understand and unpack these linkages between the intervention, the health system, and the broader context. And we appreciated that it had sort of a critical starting point around sort of the central tenet of the DDD is that sustainability is understood to be a prime service development. And because the gravitational pull of vertical disease control programs like polio is so strong, we think that putting this at the center is really important for agenda setting and planning in the global sphere. On the other side, we had some challenges with the DDD and would recommend some changes to it. One, like a lot of the literature that's out there around evaluating impacts of polio eradication or similar programs on health systems, it's quite binary. So you end up with sort of this like list of positives and list of negatives, and that doesn't necessarily get at some of the more nuanced dynamics that we would be interested in particular, assessing what those impacts are over time. With the polio eradication experience, we found that a lot of decisions that seems like good decisions that were going to lead to effective program delivery in the short term actually had long-term negative effects around the health system. And then the last kind of thing here is just some of the domains we found, as I mentioned, the integration or parallelism of the polio program within its broader implementing context was one of the key factors and should be made explicit. And also we found it really challenging to disentangle actors as sort of their own domain of interest. And we think that they should probably be put at the center of this framework. So lastly, just in terms of where to go next, we would love all of your feedback and ideas around this. In addition to these changes, we think that there's room to use systems mapping and systems modeling tools to sort of try and describe and visualize these dynamics better, actually, in terms of how those dynamics play out over time. And I hope to see that some of this emphasis around sustainability and transition should be really important here. And I guess we'd echo some of our prior colleagues as well, that these domains, I think, do pose an interesting sort of set of questions to ask and to embed within monitoring and evaluation systems, as well as in terms of planning and agenda setting, and really thinking through what are those sort of, can we broaden our understanding of what is an effective health program to understand what the long-term effects on the health system are going to be? Last slide. Next slide, thanks. Yeah, so just to close, I want to say thank you to our colleagues throughout the STRIPE consortium. It's a big team of us that have been doing this research, and to our funders at the Gates Foundation, and of course to the organizers and participants here. And I look forward to any insights that you all may have and to the discussion. Thank you.
Excellent, thank you. Joe, are you with us?
Yeah, sure, I'm here.
Great, it's your turn. Please go ahead.
Right, thank you very much, Karen, and good afternoon, good morning, good evening to everyone else on this platform. Many thanks to the organizers for the opportunity for me to share my work, which I've titled Ensuring Program Sustainability Beyond Donor Transition. Next slide, please. So we did a case study of the Gavi Alliance transition and the impact of that on the sustainability of Ghana's expanded program for immunization. So a little background. Now, Ghana's EPI program was launched in 1978 and is funded by the government of Ghana, the Gavi Alliance, WHO, UNICEF, and others. Next slide, please. However, Gavi remains the main funder of the program. And as you can see, Gavi sort of provides vaccines for the program, and 80% of the operational cost of the campaigns is also provided by Gavi, and 20% is paid for by the government. Next slide, please. Now, unlike other development partners, from this work that we have done, we realized that Gavi does have a transition policy. And on your screen now is how the transition timeline for Ghana actually looks like. So last year, Ghana entered the preparatory phase. In fact, we should have entered this phase, I think, 2 years earlier. But for some negotiations, it does happen that we started this particular phase in 2019, which is supposed to actually end in 2022. Now then we move to the next stage of transition, that is the acceleration phase, per Gavi's policy. And that starts in 2023, and then we end in 2027. And finally, the country is expected to be self-reliant in 2028. Now the question therefore is, how then will key central level policy actors, when I say central level, I mean national level actors, ensure that our immunization program is sustained beyond Gavi? Next slide. So in answering this question, next please, we did the qualitative work, mostly document interviews, and did some in-depth interviews with key central level policy actors, including government officials, civil society organizations, and development partners. And more specifically, the managers of Ghana's expanded program for immunization. And we did some thematic analysis of the data. Next, please. Next slide, please. So some key findings. So for starters, what we realize is that there's going to be a huge financial gap. It's been estimated that the on-budget expenditure for immunization is expected to rise from $10 million, that was in 2018, to $22 million by 2025. Now, we also expect to have some logistical gaps, including cold chain supply, storage issues, and then even transport. But more interestingly, what we found was that respondents thought that we are going to have some form of health systems challenges. And as expressed by earlier speakers, it does appear that there is some form of vying. So some of these funding goes into strengthening the health system. And in this particular case, we found out that some funding goes into strengthening the primary healthcare level. And so respondents felt that the transition, if not planned well, could result in serious challenges at the primary healthcare level. Next, please. Next slide, please. Next slide, please.
See, Fong, are you there?
Okay, so we also found out from respondents what strategies are being implemented to ensure that some of these gaps are closed. So it is very gratifying to realize that there is actually a transition plan that has been developed. And this transition plan is actually very broad. It's not only tailored to immunization, but there is a broad transition plan that is linked to our current president's vision of Ghana beyond aid. So we need to actually look at innovative ways of raising domestic resources to support the implementation of such programs. It's also interesting to note that already key central level policy actors have actually established a resource mobilization unit within the Ministry of Health, and their mandate is simply to ensure that we are able to mobilize the needed resources to ensure sustainability of such programs. We are also thinking seriously about creating the kind of fiscal space for the entire health sector. And if we increase that space, we are going to have financing for our immunization program beyond the Gavi Alliance's transition. And then finally, at the time that we did this research last year, there were discussions that were ongoing on restructuring the National Health Insurance Scheme to ensure that the benefits package actually includes preventive services. And possibly, I'm sure immunization is also going to be part of this basket. So by way of conclusion, the study actually realizes that generally key central level policy actors that we spoke to are very much aware of these gaps. And like I said earlier, it's very interesting to realize that they are taking key steps to ensure that these gaps are being closed, as I've shared earlier. However, there seems to be this heavy focus on the financial gaps, and this is quite understandable. I'm sure Gavi offers more than financial support. There is a kind of technical support that is also provided by the Gavi Alliance. So it's very interesting to find out the over focus on financial gaps, but that is to be expected. So in conclusion, I would like to acknowledge the team at the Center for Policy Impact in Global Health at Duke University for supporting this, and the entire team at the center for their support. Thank you for your kind attention, and I'm also looking forward to the discussions. Thank you.
Great. Judy, we can move on to you now. I will now take over the sharing of screens.
Hi, everyone. Welcome from wherever you're tuning in. First of all, I would like to acknowledge my colleagues that I worked with on a project that I'm presenting on. I'm presenting on a project which I worked on while I was in Malawi between 2011 and 2016-17. Next slide, please. So I was privileged to be involved in policy evaluation work where we evaluated a program that was funded by DFID. And we had Catherine Storin, who was a chief investigator, and my other colleagues were Marin and Jennifer, and the project was funded by DFID. So this project was on prevention of maternal deaths from unwanted pregnancy. And it was funded by UK DFID. And the funding was given to two non-government organizations, MSI, which is Marie Stopes International, and IPAS. The program was implemented in 14 countries, 9 countries in Africa and 5 countries in Asia. But in Malawi, it was only IPAS that implemented that program. It was known as PUMDAP. And the aim was to improve the policy environment for comprehensive abortion care by leading locally led changes. Next slide, please. So the main purpose for the evaluation, or the aim for the evaluation, was to answer the question, to what extent did PUMDAP contribute to abortion law reform? So first of all, we started by understanding the landscape of reproductive health policy in Malawi. That is to understand all the changes that were happening from 1964. That's when the country gained its political independence, up to 2016-17. So we reviewed all the reproductive health policies, that's international policies and national policies, relevant literature, as well as program reports, but also we interviewed key informants just to understand the everything else we could to understand about the changes that are happening in reproductive health policy. We wanted to first of all understand the changes that are already happening, and then so that we could isolate the contribution of IPAS in that context. So that was the first phase of the work. And then the second phase was to then assess the actual work of IPAS during its implementation period, when it implemented this program, which was funded by DFID, prevention of maternal deaths due to unwanted pregnancies. And we did key interviews again with IPAS, as well as all the non-government organizations who were involved in this policy advocacy work, including MSI, because we wanted to understand the relationship between IPAS and MSI in Malawi, because at international level, they were both responsible for implementing this project. So we did several rounds of interviews because we're following up key events that were happening at that time that led to the development of a draft termination of pregnancy bill. But also we observed different events. We observed the specific activities that IPAS was implementing through the coalition that it was developed. At the same time, we're also tracking the media to sort of understand the discourses that were happening around reproductive health, family planning, and abortion care, as well as abortion. We sort of took that broad overview because in 2011, from that time, it was not, abortion was still controversial to talk about. Even the interviews, we were sort of starting to interview people indirectly, starting with asking them questions around reproductive health more generally before we could probe into abortion, whatever was happening around abortion policies. So we also followed some radio programs and even some newspapers to sort of understand the discourses that were happening at that time. Next slide, please. So before I can talk about this slide, so I said that in our study, we first of all looked at the context within which reproductive health context, so that we could understand the role of IPAS in the whole reproductive changes that were taking place. So some of the key contextual factors that acted as a driver to the to abortion law reform, they included, for example, there was an expectation for Malawi as a government because to demonstrate compliance to international and regional agreements on reproductive health, particularly looking at human rights agreements on access to reproductive health services, especially among women. And another example was regional agreements, especially through the African Union, that they developed the Maputo Plan of Action. So there was quite a push from international and regional level for the government to demonstrate compliance, that it's making progress towards improving reproductive health services and providing access to reproductive health among women. Another important event was actually there were attempts from 2002 to request the Malawi Law Commission to change the abortion law, because since independence, we've had restrictive abortion law to the extent that in the public sector, a woman cannot access safe abortion services because of that. So those attempts were not successful. And then in 2012, there was a call to Malawi Law Commission as well through Ministry of Health to actually reform the abortion law. And the Malawi Law Commission's response was to say there wasn't enough evidence locally generated to support that sort of move. As a result, IPAS, WHO, and Center for Reproductive Health Research, they sort of commissioned research specific on abortion laws, specific on the magnitude of abortion and complications of unsafe abortion. So these events, they were key that they led to the development of a special commission on abortion law. And this commission was responsible for conducting stakeholder consultations, consultation with the public, but also developing the draft bill for termination of pregnancy. Now, I think the task was then to isolate the role of IPAS in that context where change was already taking place. When we started looking at understanding the work, the advocacy work that IPAS was responsible for, we found out that IPAS worked from behind, in a sense that it worked through a coalition. So after the specific studies on abortion, there were dissemination meetings, and during these dissemination meetings, non-government organizations, they came together and developed a coalition to sort of follow up the government on how it's going to take actions to address the issues that were addressed in the recommendations that came up during the studies that were specific for abortion. So, and then at the same time, at international level, there was a shift in the scope of work that IPAS was doing. So it shifted from supporting health system strengthening to policy advocacy only. So it had a strategic advantage in a sense that it had earmarked funding for policy advocacy, but also by that time it had strategically positioned itself to work within Ministry of Health, even within the premises of reproductive health. So, and then because it had that advantage, it had financial capacity. So it used that strategic position to strengthen this existing coalition, and then sort of developed a clear structure with advocacy groups which were focusing on health professionals, lawyers, members of parliament, adolescents, and even government officials. And then using these sort of structures, they actually developed a very comprehensive advocacy sort of they implemented advocacy activities which included campaigns.
Last 30 seconds, sorry.
Okay, so they included campaigns and lobbying and negotiating for abortion law reform. Next slide, please. So in instance, we can say that IPAS worked in the background in that it was the COPWA, this coalition, which became the face of the policy advocacy work. But what it achieved, next slide, please. Oh, okay, that's the slide. So what it actually achieved was that it helped to frame abortion as a problem in the public health arena, but also it brought the discourses around abortion and reproductive health, women's rights to accessing services in the forefront of the decision makers, but also it intensively negotiated and lobbied for this law reform to happen. But also it participated to put together evidence and draft the termination termination of pregnancy bill. So that was the achievement. I guess my time is up. Otherwise, you can follow me up with the questions. I'll be in a position to answer. Thank you.
Great. Well, thank you so much for that. I'll pass the floor over now to Kathy, who is going to lead us through some of the questions that have come in over the last hour through the Q&A from people listening in.
Right, so thank you for that. And we thank all of our speakers for very interesting presentations. And we also received quite a number of questions from our participants. And let me pose the first question around accountability. So our topic for tonight is on the donor and government tension. And we have this question on accountability. So how do we deal with the issue of accountability, particularly to donors, as you try to increase country ownership of programs? So who would like to answer that? Who would like to take the first answer to the question around accountability? Can we have Sara? Yeah, Sara?
No, I saw Sumegha wanted to talk. I'll let her go first.
Yeah, thanks. I don't have an answer to this, but I just want to bring in a little finding from my work around on bank. While talking to the bank officials who were involved in health system strengthening projects at various levels at the global team and in India, there's a general sentiment around that we work on country's demand. Whatever the country demands us to do, we do. And in this situation, the question around accountability gets very messy and fuzzy. So on one hand, I have quotes from the respondents from the bank side saying that we're just a bank. We just give loans to whatever the country demands us to do. And on the other side, we have had respondents telling us that how the bank actually told us how to write bank projects, how to write proposals. They actually came to us with proposals and told us that this is the possibility, this is possibly what you can demand from us, and you have to write in this way. It's very fuzzy to delineate, who's accountable for what. So when things go wrong, it largely is the country ownership. And when things go right, it's always like, oh, we did this. Our money made this change. And it's not just for the bank. It's for many other actors, including the bilateral and the other multilateral agencies. One more point that I'll try and bring in here is that this whole network of global actors which work in this space of in the donor space, it's further complicated to pinpoint accountability because they work in such a network that it's really difficult to say who actually influenced a particular idea or a particular change, who should be held accountable for what went wrong, not just the state or the donors as binaries, but also among the donors. Especially in the disease-specific projects, a lot of global actors come together and take different components of these projects to support. Over.
All right, thank you for that. I think Sara also wants to share her thoughts, and then Ligia.
Yeah.
Sara?
Sure, thank you so much. I think what Sumegha already said is spot on, really, and I'll just add, because I've been looking at a lot of these sorts of questions as well throughout my dissertation work, and I think part of the problem is that there can be accountability from a lot of different levels, right? So there's donor accountability, There's implementing partner NGO, whatever you want to call it, accountability. There can be national government accountability, district government accountability, frontline worker accountability, community accountability. So there are a lot of different ways that we can talk about accountability, and it really depends on, I think, the focus of the project. I think it depends on the strength of the actors who are working around these things. So, in the case of at least my presentation here about ownership, I think, if you want to promote real ownership, then I think that accountability has to be a sort of two-way street, and I think it needs to go sort of in both directions. So as Sumegha pointed out, very rightfully so, right? Like, it's very often donors, et cetera, who take credit for wins and will just push away any credit for failures or not as great successes as they would like, and push that back onto either systems problems or government corruption, or there's something else, some red herring to blame. And I think that kind of thinking has to change, and the sort of incentive system, the entire incentive system around aid, I think we really need to re-examine what incentives are given to claim success.
Thank you for that. And Ligia?
Thanks, Kathy. I think this is it's an important question, and I guess it makes me think of I guess in the context of the presentation I made about the spaces that where power manifests itself, and I think that it's helpful to think of as Sarah mentioned, there are different forms of accountability. It's important to ask to whom and for what, and then when these spaces where decisions are are formed, who is participating. For example, in our case, we were noticing that even where, let's say in the accountability for services, where rubber hits the road, are people getting the services that they need? There was very little communication to the purely local patient level, and civil society, who technically represents the local level, let's say, was invited only to some of the spaces where decisions were made. So I think that, who do we hold accountable for country ownership? I think that it's hard to, point the finger to one place or one entity, especially because a lot of these programs have been run in partnership. And as transitions give us an example of, these partnerships don't cease to exist overnight, whether they're, good partnerships or bad partnerships. It's sort of more of a continuum. And so I think it's important to try to understand the ownership perspective from multiple perspectives, and give it that nuance. And that's, one of the opportunities in policy analysis, especially when looking at implementation.
All right, Judith, you also have something to share on this topic?
I think based on what I've presented, accountability, it's a difficult conversation to isolate, but I look at accountability as also a capacity that needs to be developed. I think in the case that of IPAS working with a coalition of non-governmental organizations, its aim was to actually support locally led changes. But I think because the capacity for the local non-government organizations to actually implement that sort of work independently with support was not there, and then IPAS ended to lead the whole process, because in the end, IPAS had to be accountable for the resources that were earmarked for the advocacy work. So I think accountability is also a capacity that needs to be developed if we're talking issues of ownership and sustainability. As I'm talking now, the funding stopped in 2016, and the work was also affected, and it wasn't finalized. Although we have a draft termination of pregnancy bill, it still hasn't been passed, and there's no one else to carry on that work to the extent that bill is passed, simply because of that accountability capacity to carry on the work, but also to be accountable for the outcomes of the policy advocacy work that was done in Malawi.
All right, thank you for that. So it really shows the multiple, still the complex nature of accountability and how we monitor or measure it. in terms of donor relations. You have anything to add, Abby or Joe, before we move to the next question?
Yeah, so thanks to all the other panelists for their contributions. I mean, I did not actually look at accountability within the perspective of my work, but I work with the Ministry of Health. And it's very interesting to note that the Gavi Alliance, for instance, has its policy that ensures that there are stages of transition and is actually holding the country accountable. So there's transition timelines. But it begs the question, should this be the case? I mean, I also pointed out a situation where the country had defaulted in its co-financing requirements, for instance. And so we are talking about ownership. I mean, you would want to ensure that children are immunized and they're healthy and all that. So it's a really tricky one. But from my experience working at the Ministry of Health, I think that the issue of capacity also comes in, because you ask yourself whether people are actually ready to be accountable for their actions, their decisions at the national level, you know. So it's a very tricky one, but I feel that if we want to talk about ownership, I mean, who designed these programs? Who owns these programs? These are the questions that begs on accountability. And so the laxity around central level policy actors and how they respond to donors, with my experience working at the ministry, I think needs some kind of cushioning, because it doesn't appear to be forthcoming. So that's a little that I would want to add on the issue of accountability.
All right, thank you for that. So I think we can now, Abby, before we move to the next question.
I can speak, or if you want to move on, that's okay too.
Okay, so probably in the next question. Okay, so the next question is on power, and it's related to the objectives and the indicators that are usually attached to the work of the donor. So the question is the type of objectives that the donors often have to fulfill within a certain project. How does this feed into the power structure of the relationship between the donor and the country, and how does this eventually link to the sustainability of projects? So, can Abby, maybe you want to start commenting on this question?
Sure. I mean, I think it's really related to a lot of the concepts that my colleagues were just bringing up on the last question around accountability. I think one of the things maybe that came out of our work in the presentation I made today was that sometimes setting up sort of those perverse incentives where you are accountable to a set of objectives or indicators that might not be necessarily aligned with national and, as Ligia said, you know, local or community level priorities, that can kind of the power dynamic of the global actor sort of setting what that's going to be and sort of kicking off that first incentive that you need to focus your time and energy on something else. Then we go back and say, well, the health system's not sufficient and it's not being accountable to itself or its communities, and so you need our help more. And so I think we kind of create a problem and then don't know how to get ourselves out of it. And I think that sort of part of what's at play there is that inherent power dynamic, that accountability isn't the same between these levels. And I think trying to sort of shift that accountability so that's a bit more bi-directional would be really helpful in thinking through this. But that would also, I think, requires a bit of a seismic shift from donors thinking about more openness to a lot more distal sort of indicators rather than sort of needing sort of proximal quick return on investment kinds of things when they're looking at monitoring and evaluation of their programs, which is a big shift.
Anyone who wants to add on that? Ligia?
Yeah, I guess that's an important question, and you know, I guess again in the context of the GP that I presented on, you know, technically the let's say at the global level, because I do think that there are layers and there are different indicators at different layers, and they may, you know, influence the ownership, the sustainability of the programs, right? So at global level, one could argue that at very broad levels, there is sort of global agreement, or you know, all countries bought into the 90-90-90 targets that UNAIDS set in this case, right? So it's, you know, if it's under that broad umbrella, then the donor and the country are technically working together. But where I think that there are disconnects in how those targets are reached, and that probably varies by country, but it also varies within countries. So for example, when PEPFAR was supporting some of the programs, they also focused a lot or placed more emphasis perhaps on certain types of key populations and vulnerable populations that may or may not feature as priority, you know, indicators or targets in some settings versus others. So, you know, that there could be some potential conflict there, and, you know, whether or not something is sustainable in that context is, you know, depends on how things shift post-transition. And moving closer to local, I do think that there is a lot that districts have to say on, you know, what should be priority indicators, and, you know, that perhaps highlights the disconnect between sort of the global, you know, targets and what actually happens at the district level. And I guess the example is that, you know, we were hearing that in some of the counties and districts where the support was discontinued, that there was perhaps a resurgence of HIV, and, you know, that might not show up in the data at the national level or at the international level for a while, but district officials at the health facility, they are the ones who are sort of the litmus test for that. But, you know, do they have the power then to influence sort of the cascade up? Is, you know, probably, you know, depends on the situation, and often that is an imbalance in power. So I think that the indicators are important to look at, but I do argue that, you know, it's important to look at them from multiple levels, because they have different significance, and there are different actors involved at each.
Right.
Do you want to move on? You can move on.
Sara? No, it's okay. I think we can still take one comment before we move to the next question.
I'll make it
Sara?
super short. I'll make it super short. I know we're running out of time. I think these are good points. And I like the whole like indicators and targets conversation is a huge one, of course. And I think it depends also a little bit because it differs by program and by donor often. So like in Ligia's case, right, like HIV and PEPFAR, for example, they're like notorious, right, in development circles or in global health circles for being really strict. I mean, it's US government funding, and the US government is like, we all know, I mean, this is not a surprise, right, that they're much stricter about setting their targets from kind of maps they see in Washington, and that's the end of the conversation, right? But there are not all donors are that bad. I mean, all donors have some idea of targets and things, but it's a little bit different. So I think if we can sort of elevate the conversation around the donors who are trying a little bit to bring in more kind of you know, to kind of shift these power dynamics down, or, you know, like a really good example from Malawi is ICEDA, you know, the Iceland Development Group, and they work directly with the district, and they channel all their funding directly to the district, and they really work really closely in partnership. And those are the kinds of, you know, there are still power dynamics there, of course, but I think it makes it a little bit easier for countries and for districts, particularly if we're talking about the subnational level, to kind of work these things out. So that's all.
Right. Thank you for that, Sara. So we have had discussions around accountability and the objectives and how this figures into the sustainability of programs organized between donors and countries. And now I would like to go to another interesting question. I think something that would tie some of your work together, and perhaps also the future discussions around this topic, is the question around global ethical guideline for donor organizations, and especially on how they support country-specific agenda. So I understand that there are already some conventions around ethical guidelines of donor relations. So drawing from this question from our one of our participants, is this still relevant, or is there a need to revisit these guidelines that we have at the global level, especially in the context of our current situation? Ligia?
This will not be a complete answer to the question, but it makes me more interested in global ethical guidelines and what's been sort of the background on that. But I guess just as a reflection, I think that there is a responsibility, for example, and it's a joint responsibility to ensure that there are no negative spillover effects, because we've talked a lot about, initiatives, right? So obviously the HIV is a very vertical program. The GPA, the Polio Eradication Initiative was very vertical. Sometimes looking at particular services like abortion care, can be, we want to look at them perhaps in isolation. And I think that when funding comes in and out of those, and this is perhaps also relevant to the broader COVID response, it's important to look at, to make sure that the local priorities and the ones that, are indeed, supporting the communities and make a difference are being kept, and there are no negative spillover effects. And some analyses on that have been done. I guess in the context of HIV, there was always a question of, our MCH primary healthcare services at a disadvantage, and I think that more questioning along those lines would be helpful. Now, whether the ethical guidelines could bind all that together, it's possible. I don't know enough about that though. So just a couple thoughts on that.
Okay, thank you. Who wants to answer that question? Sumegha?
I think I'll just take a slightly different take on this and say that I don't know about the global ethical guidelines, but the guidelines at the country level should definitely exist. Each country should have a guideline for accepting aid, what form and in what areas do they actually want to accept aid. And especially for countries like India, which do not actually need a lot of money from these donors, what is it that they actually need the support for? And they should constantly monitor not just the impact in terms of program interventions and service delivery, but the larger impact on the ideational normative level that the donors are impacting the health systems at. More work needs to be done there to understand these kind of influences, which are shaping our ideas of understanding health systems and developing health systems. Then, I think that there's a need to transition from that idea of mere service provisioning and supplies and equipments and drugs to now understand why do we need international aid, especially for non-aid dependent countries. And it'll be good to have policies for different countries according to their own context. And I know India has been revising these policies, but even after that, it's time to revisit them maybe after 5 years, then having a global compact and have one kind of standard guideline, which might not hold relevant for different contexts. Over.
All right. Anyone who wants to add on that question, wants to answer that question?
Sure, I can. I guess I also am kind of interested, I guess, to learn more about these global ethical guidelines, and I would echo Sumegha that having some variation would be probably very critical. But I think I wonder if maybe there's a distinction between sort of principles and policies. So I like the idea of possibly using some policy to kind of try and deal with some of the power imbalances that might be at play, and sort of protect some of the groups that might otherwise not have as much power in decision-making space. And at the global level, maybe there's something more like some sets of principles that we can think about that we would want to sort of adopt and try and generate buy-in and political will around. I think that our work emphasizes sort of needs to think through unintended consequences and issues of sustainability earlier in the process. And the polio experience, particularly at the community level, I think that they started engaging with community needs when they had demand challenges and mistrust issues. And so I think about if there are principles that could sort of bring some of those things more to the forefront at a global level, and maybe at a national and local level, some policies that have more of a protective element. I don't know what those would be, but I'd be interested to hear ideas.
Okay, thank you for that. Karen, I'd like to confirm if we are, yes, Judith, before we move to our last question.
Yeah, just a few things. One thing probably to add. Really, I'm also interested in following up those ethics. I think my interest is looking at because it's just technology. Really, there've been conversation about how donors should work together, particularly in strengthening the governance capacity. Because, but then. I don't know, it's because of power issues and all that, then the same donors who have those principles or guidelines, then they tend not to follow those principles. A very good example is where we have the principle of health system strengthening, where you had a wider sector approach. The purpose was to strengthen the capacity of the health system to manage resources from different donors. But then because of course the capacity was not built, and then different donors are now funding directly through projects, through discrete non-government organizations, and that sort of does not really align with the objective of strengthening the capacity, the governance capacity of the recipient organizations. I don't know if there's been an opportunity to sort of evaluate the previous principles and see what went wrong and all that stuff. Yeah.
Okay, so we yes, Joe, you would like to say last comments before I turn over the floor to Karen?
Yeah, just a word. I think that there's no right answer for the question, and for me, there are already existing global health agendas. You can have something like SDGs. Meanwhile, you do not have a system for ensuring that countries adhere to some of these things. So it's a question of enforceability of some of these global health principles. And so I think that's the discussion, because from the sentiments that have been shared so far, it does appear like everybody feels, I mean, if countries are strong enough to have their own systems to ensure that they whip donor agencies into line, then they are cool. They can move on with whatever that they're doing. But I think that speaking within the perspective of COVAX facility for vaccines, for instance, you have very powerful nations pulling out of this, wanting to ensure that as soon as there is availability of vaccines, their country receive it first. So who is that authority to ensure that people adhere to some of these global health principles? I think that's a bigger question that we should be asking ourselves, how to ensure adherence to some of these principles. Thank you.
All right, thank you for that. So we have had very interesting discussions around accountability, alignment of objectives, and as well as some ethical principles around the donor, the government and donor relationships. So I'd like to turn the floor over to Karen.
Yes, well, thanks, Kathy. Thanks for moderating, and thanks to all of our fantastic panelists for sharing their research with everyone tonight. Normally at the end of a session like this, we would now have a coffee break. You could have a chance to get up and interact with the panelists, ask your questions. Unfortunately, we can't do that. So what I would encourage you to do is to follow up with anyone that you didn't get a chance to ask your question to. If there's a presentation you really enjoyed, please reach out to them. A lot of them are on Twitter. Feel free to follow them, start engaging with them. We'd really like to build a community around the people you've met. Pretend you've actually really met the panelists and take that home. I feel like I met many of the people here today, so that's great. Anyways, if you could put the last set of slides up, just a quick reminder, there are ongoing sessions that will be happening as part of the symposium. So join us in a couple of weeks where we'll have the third panel and the fourth session on the politics of regulating health commodities. and then there's a couple extra panels after that. So follow us on Twitter, follow us on our website to keep in touch, and we hope to keep seeing you at these events in the future. So have a good day, good night, vote if you're American, and be safe.
Thank you so much.
Thanks.
Thank you.
Thank you.
Thanks, everyone. Have a good night.
Bye-bye.
Night, whatever. Keep forgetting. Bye.